Good morning. Myself Dr. Nutta Nadia. I am currently working as an assistant professor in the Department of Cardiothoracic and Vascular Surgery in UN Mehta Hospital and Research Center. Today we are discussing the topic of atrioventricular canal defect. Coming to the medical management of the patient, it is not definitive, it is only used as a bridge to surgery in these patients before planning and before understanding the anatomy in these patients. First one is the heart failure management, for which you can use the diuretics, digoxin, ACE inhibitors, spironolactone, high calorie fluids and treat the anemia if any. For pulmonary hypertension management, supplemental oxygen, avoid hypoxia, milrinone, sildenafil, inhaled nitrous oxide you can give, bosentan also can be used, and fluid management is necessary. For infection prevention, bacterial endocarditis prophylaxis for dental and invasive procedures, routine vaccination and prompt treatment of the respiratory infection is must in these patients. Coming to the surgical management, what are the indications of surgery in these patients? So, if there is uncontrolled high failure, complete surgical repair as soon as possible is the class 1 indication in this patient. If there is a controlled heart failure, complete surgical repair by the 3 to 6 months of age is the class 1 indication. For partial and intermediate AVCD stable with normal pulmonary artery pressure, surgical repair by 2 to 3 years of age, and surgery for moderate to severe AV valve regurgitation has to be done with repair of the AV canal defect, that is the class 1 indication. Surgery for LVOT obstruction is reasonable with peak systolic gradient of less than equal to 50 mm of Hg or a lesser gradient if heart failure symptoms are present or if concomitant moderate to severe atrioventricular or aortic regurgitation is present. Class 2B indication for complete AVCD is pulmonary artery bending may be considered in selected patients under 3 months of age. Beyond 6 months of life with significant pulmonary hypertension and suspected pulmonary vascular resistance or pulmonary vascular disease, you have to evaluate the patient to assess the operability before going in the surgery. Pulmonary artery bending is reserved for complex cases only with contraindication for cardiopulmonary bypass, that is the class 2B indication. AVCD with the severe pulmonary artery hypertension or irreversible pulmonary vascular disease are non-operable, that is the surgical contraindication, class 3 indication. Coming to the conduction, before going for the surgery of this patient, we have to understand the anatomy of conduction system in atrioventricular canal defect, which is the nodal triangle. In normal heart, the AV node is located in the triangle of Koch, that is here, but in the patient with AV septal defect, the AV node is located posteriorly somewhat. It is situated in the triangle that is bridged by the coronary sinus, the atrial component and the posterior bridging leaflet of the common AV valve. What are the strategies to avoid the conduction system during surgery in this patient? So, diverting the coronary sinus to the left atrium at the cost of some insignificant desaturation is the first step you can take. Another one is sewing the pericardial patch of the ASD to base of the left AV valve tissue, taking superficial bites in the conduction area, following the RA wall to the suture ASD patch, going to the bottom of coronary sinus away from the AV node before transitioning the patch to the ASD margin. These are the things you can do to avoid the conduction system or block in these patients during surgery. Coming to the partial AVCD repair, as we have seen previously, it is a mainly the ostium primum ASD is seen with no VSD or the VSD is already closed off the by septal tissue, and with that you can see or you can also observe the cleft in the left AV valve orifice, but here on there are separate AV valve orifice, so it is not a problem in this case. The approach is the same. Right atriotomy is used, standard bicaval cannulation is used, myocardial protection should be must in these cases. So, we start by right atriotomy, and after right atriotomy we observe the structures that are seen, where is the coronary sinus we have seen, if there is any VSD or small VSD opening is left. With that we close the partial AVCD or the ostium primum ASD with the pericardial patch. We start with the crest of the ventricular septum at the annulus of mitral. Horizontal sutures are placed and the atrio ASD is closed. After half of the ASD is closed, we see for the mitral valve cleft. Mitral valve cleft must be sutured with Prolene 6O in an interrupted manner, and after that we check for the mitral competency. If there is any competency issue, we can also do annuloplasty sutures in this patient to avoid this. And after that we close the primum ASD, and we also check the tricuspid valve for the competency, and if any repair is required, it should be done. So that is the partial AVCD repair technique. Coming to the complete AVCD repair technique, there are three main techniques that we can use: single patch, double patch, and the modified single patch technique. We most commonly used is the double patch technique for complete AVCD repair. Single patch technique, which was first described here, as you can see, with bicaval cannulation, both KY are sned, right atriotomy is done parallel to the right AV groove. After we open the right atrium, this is the surgeon's view that you can see, and here also you have to assess the anatomy first for any surgical repair. Left AV valve regurgitation is checked with valve competency water. After that you can see the point of opposition in the leaflet, where you have to take the stay sutures and you have to cut the bridging leaflet where this point is located, so you can divide the bridging leaflet, as you can see in this picture. After that, the starting of VSD closure is done. For better exposure, the retractor is placed here somewhere, and the pledgeted interrupted sutures are used on the right side of the ventricular crest to avoid the hitting of the conduction tissue. These interrupted sutures are then passed through the bridging leaflet. Yes, you can see with the pericardium. It will be a sandwich, like you can see in the image, where lower VSD sutures, the bridging leaflet, and this. Here also you can see the passing from the patch. After this has been done, you have to assess the left AV valve, where you take the interrupted suture to close the cleft, and then you complete the ostium primum closure using the single patch. This is the single patch technique of AVCD. Coming to the double patch technique, here you can see the dotted line that describes the conduction tissue in AV canal defect. Here also you start by right atriotomy only, but for a VSD closure you use separate Dacron patch, and from ostium primum closure you use the pericardium patch. For VSD closure, half circle patch is used to of adequate size, not too redundant, that will cause the RV outflow obstruction. After the closure of VSD, we use the interrupted sutures that pass from the leaflet, the crest of the patch, and then through the pericardium. It will also make the sandwich, and then we take the pericardium below, and after that we checked for the mitral valve competency. Mitral valve cleft is closed. Then again check for the mitral valve consistency. If there is any regurgitation still present, then you can do the posterior annuloplasty in these patients, or a commissuroplasty. This care must be taken to avoid the stenosis at any cost. After that, ostium primum is closed. After ostium primum closure, the right AV valve is assessed for any regurgitation or stenosis, and it is repaired for any regurgitation. The main advantages of double patch technique is the maintenance of planar alignment of the AV valve, lower chances of narrowing of the LVOT, preserving the integrity of the bridging leaflet, and it does not compromise the ventricular volume. Here you can see the common AV valve surgical anatomy and face view. It is basically a 5 leaflet architecture. As you can see, superior bridging leaflet, inferior bridging leaflet, right leaflet, and left leaflet. The cleft closure is the most important step in the repair of common AV valve, where you can start at the annulus, work towards the periphery. Interrupted 5O or 6O polypropylene sutures are used, as you can see in the figure. Saline test after each suture is important. Stop if closing leaflet, closing cleft closes a stenosis. Stenosis should never happen in the repair of AV valve. Critical surgical principle is that the cleft in the superior bridging leaflet must always be closed even if there is no regurgitation, because unclosed cleft lead to mitral regurgitation and it will require reoperation in the future even if there is no regurgitation at the point of repair of AVCD. Coming to the Nunn's modified single patch technique that is developed with, there were no VSD patches used, valve tissue pressed against the crest of ventricular septum, AV valve sutured directly to the septal crest, obliterating the VSD. There is only single pericardial patch is used and it will require the adequate valve tissue because the valve tissue leaflet are pressed against the ventricular crest. Advantage is the shorter CPB time, less suture near the AV node, no VSD patch, so no risk of residual, technically faster. But there are some limitations that seen with this technique. There is length check is critical. You have to check for the adequate valve tissue before going for the modified single patch repair. There is a higher valvular leaflet tension and it is required operator's experience before doing this technique. This table shows the comparison of three techniques that we have discussed: the single patch, double patch and the modified single patch technique. For type A and B only we can use modified single patch technique. For type C we cannot use modified single patch technique. For VSD patch requirement is not necessary for modified single patch technique, but for single and double patch it is required. CPB time is much shorter for modified single patch technique and residual VSD risk is very low. The reoperation risk is almost same in three techniques with a only slight difference of 8 to 12% at 10 years in single patch, 8 to 10% at 10 years in double patch and approximately 8% at 10 years in modified single patch risk. But the conduction block risk is very low for the modified single patch technique, but valvular retention is very high on leaflet using a single patch modified technique. These are the echocardiographic goals post bypass, which is the residue. You have to assess for the residual ASD, minimal due to clear exposure of the atrial septum to the right atrium. Assess for the residual VSD. If less than 5 mm, no intervention, but if more than 4 mm, you have to go for the second bypass. AV valve regurgitation and stenosis. Left AV valve regurgitation, interface of superior inferior bridging leaflet, regurgitation jet area should be calculated, and according to that we have to take the decision for going for the second bypass or not. If there is any LVOT obstruction is present, you have to check during the echocardiography, and biventricular function should also assessed post bypass during echocardiography. Coming to the post-operative management, you have to maintain the sinus rhythm because junctional rhythm is common and it is transient. Target heart rate should be 130 to 150. In infants, dopamine and epinephrine can be used for low cardiac output. Milrinone to reduce the pulmonary vascular resistance to improve the LV relaxation. Avoid tachycardia because it will increase the mitral regurgitation further. Fluid management, moderate fluid restriction should be used and diuretics can be used for post-operative management in this patient. For pulmonary hypertensive crisis, the major thing you can do is avoid it. Avoid hypoxia, avoid hypercarbia, avoid acidosis, avoid pain and avoid suctioning as much as possible. For treatment, you can use inhaled nitrous oxide, which is the first line of treatment with 20 ppm of pressure. IV sildenafil and milrinone can also be used in these patients. Early extubation in uncomplicated cases is beneficial, but if the patient is in PH crisis or the low cardiac output or significant residual lesion, you have to go for the prolonged ventilation in these patients. What are the complications that we can see post-operatively in these patients are mitral regurgitation is the most common complication that we can see post-operatively. Residual ASD, VSD, subaortic stenosis, complete heart block, junctional rhythm, atrial fibrillation and flutter you can see post-operatively. The subaortic stenosis is common in 5 to 10% of the patient after the repair. The surgical relief we can do is by membranectomy or myomectomy, Conor-Rastan procedure, biventricular repair avoided with borderline LV dimensions. For residual and recurrent MR, which is the most common reoperative indication, most common cause of residual or recurrent MR is half or partial cleft closure, or there is incomplete repair during the first repair, or there is a progressive annular dilatation that happens. The unclosed or reopened cleft should be closed again. The annular dilatation, annuloplasty sutures can be used. The leaflet prolapse, the cordon shortening can be used. For patch dehiscence, you have to revise the whole procedure for prevent residual mitral regurgitation. For conduction complications, AV node anatomy is the key risk factor in this patient because the anatomy is different than other patients in these cases. Post-op conduction issues are complete heart block seen is 1-3% of cases. Junctional ectopic tachyarrhythmias and atrial fibrillation and flutter should be treated adequately during post-operative period because it is much more common in post-operative period in these patients. For left AV valve regurgitation, reoperation is 3-18% for partial AVCD and 6-14% for complete AVCD. Reoperation techniques are annuloplasty sutures, caudal replacement, leaflet edge-to-edge repair, the anterior leaflet pericardial patch. Extension can also be used, as you can see in the figure, for residual or reoperation of left AV valve regurgitation. If after this also regurgitation is still there and or there is a strict indication of left AV valve replacement, it should be done with age augmentation of the pericardium and on that valve is seated. There are some special consideration that should be given in patients with AV canal defect. These are the AV canal defect with a tetralogy of Fallot, AV canal defect with DORV, unbalanced AVCD, double orifice left mitral valve, absent posterior leaflet. 6-16% incidence of seen in Atrio Ventricular Canal defect with tetralogy or Fallot. In this patient, there should be a satisfactory exposure of VSD to ensure that VSD patch is appropriately contoured, thus avoiding the residual RVOT obstruction. Right and left AV valve regurgitation coupled with pulmonary valve regurgitation post-operatively can lead to poor outcome in terms of risk of death and post-operative morbidity. Reduced mortality rate of this rare combination of defects from 29 to 40% to 0-11% in recent years has been studied. AVCD with DORV, the incidence is less than 5%. In Rastelli type C patients with large subaortic VSD, the LV can be tunneled to aorta as long as there is a sufficient ventricular-infundibular fold dimensions to minimize the RVOT narrowing. Biventricular repair, that is the tunneling of VSD to the aorta and right ventricular to PA conduits, is feasible in the absence of contraindications such as straddling of atrioventricular valve or severe heterotoxy with anomalous pulmonary venous drainage. In AVCD with subpulmonic VSD, arterial switch procedure with tunneling of left ventricular to aorta is the procedure of choice. Unbalanced AVCD, the main question here arises whether to go for the univentricular repair or the biventricular repair. Surgical decision making is the must in unbalanced AVCD. Biventricular repair can be done if ventricles are adequate with standard 2-patch or single patch technique. 5-10% operative mortality. Risk of low cardiac output from underdeveloped ventricle is more in these patients. For stage single ventricle palliation, if there is a severe unbalanced AVCD is present. At stage 1, we can go for Norwood or hybrid procedure or PA band, and for stage 2, which is done at 4 to 6 months, you can go for bidirectional gland shunt. For stage 3, that is 2 to 4 years, you can go for Fontan completion. For 1.5 ventricular repair or where the case is intermediate, you can go for biventricular repair plus BD gland shunt. It will offload the hypoplastic right ventricle while maintaining the biventricular circulation. It is used when RV is borderline blood, not hypoplastic. Though it is candidates with highest risk groups, individualized decision making is must in these patients. These are the AV valve consideration that should be considered in patients with AVCD during surgery. The common AV valve is often maldistributed, more tissue over dominant ventricle. During repair, valve division must account for its asymmetry. Smaller valve orifice may need augmentation with the pericardial patch, and for AV valve regurgitation, it is the major determinant of Fontan outcomes, so it should be addressed effectively at each stage of single ventricular repair. Double orifice left ventricular valve. there is one study that was published in 2003 that complete atrioventricular septal defect in Down's patients, the surgical outcome, where the association with single papillary muscle which may require fenestration, though conservative management is recommended. The 11 patients out of 147 patients of AVCD are present with double orifice left ventricular valve. Here is the graph. Both graphs shows the survival analysis of patients up to 30 days after the surgery and survival analysis of patients more on long-term follow-up after the surgery, which is equal. Another paper published in American College of Cardiology journal in 2025 was the clinical practice algorithm for follow-up of repaired and unrepaired atrioventricular septal defect that must be learned by all before going for surgery of AV canal defect. Here are the algorithm that is less than 18 years of age, more than 18 years of age, and here is the algorithm for repaired AVCD these patients. Another paper published in 2026 January in Cardiovascular Medicine, repair of partial and transitional atrioventricular septal defects, midterm outcome in the small center cohort. Here the 136 patients were studied with median follow-up 50.5 months and median hospital stay of 14 days. Excellent overall outcomes has been seen with minimal mortality and reoperation left. Left AV valve repair strategy was the key determinants of the midterm outcomes. Older patients and those with the annular dilatation benefit most from ring annuloplasty. The transitional AVCD has a slightly higher risk of valve-related reinterventions than partial AVCD. The age-dependent strategy for AV valve repair is recommended. Here you can also see the partial and transitional AVCD outcomes or reoperations after surgery. Another paper that was published in Interdisciplinary Cardiovascular and Thoracic Surgery in 2024 was the repair of complete atrioventricular septal defect with impact of post-operative moderate or more regurgitation. Summary, it was the retrospective analysis of 220 patients with intermediate post-operative moderate or more left atrioventricular valve regurgitation after complete AVCD repair contributes significant to the mortality. The second run of bypass should decrease the observed mortality should be investigated. So there is an increased mortality and morbidity in patients with repair of post-operative moderate to more regurgitation. Another paper that was published in 2025 was the long-term outcomes following atrioventricular septal defect in adult patient. Here the 168 adult patients with median age of 36.4 years were studied. 160 patients are post-operative LAVE regurgitation. Cleft closed completely in 155 patients. 36 patients required mitral valve ring annuloplasty. 18 patients needed additional valve procedures. Here you can see in the graph the retrospective cohort study of reintervention, death, and alive and reintervention free patients in this study. Another paper was published in 2022 of middle and long-term outcomes of surgical repair of atrioventricular canal defect, single center study. That is total 150 patients with 10 years of follow-up period were studied in Children's Hospital of Fudan University between 2013 and 2021. Total mortality rate was 5.33. Conclusion was mortality was higher after surgery in complete AVCD, while freedom from reoperation and left atrioventricular valve reoperation rates were similar in all types. Severe PAH before surgery and severe left atrioventricular valve regurgitation within 24 hours were the risk factors for the mortality. Here you can see the Kaplan-Meier survival curve of complete AVCD, transitional AVCD, and partial AVCD in patients with complete atrioventricular canal defect and the cumulative survival percentages, which is much higher in complete AVCD. Another paper published in 2020, complete atrioventricular septal defect repair in Australia, result over 25 years. Here atrioventricular septal defect, both technique were used for a closure, double patch repair and the modified single patch repair. 223 patients in both the group. Similar overall and event-free survival in both groups ever seen, and similar rates of reoperation for left atrioventricular valve regurgitation and left ventricular outflow tract obstruction were seen in these groups. Another paper published in 2019 was the long-term results after the surgical repair of atrioventricular septal defect, that is published in 2019, between 1998 to 2017, 508 AVCD repair was done, 359 surgery for complete AVCD, 76 for intermediate and 73 for partial AVCD. Median age was 6.1 months, median weight was 5.6 kg. The standard AVCD repair was performed using 2-patch technique and the complete closed repair. The results were divided between 1986 and 2004 and 2004 and 2017. The key question was what are the risk factors for the death and reoperation after repair of an AVCD. The key finding was risk factors for death and reoperation are the age less than 3 months, complex AVCD and atrioventricular regurgitation. Take-home message was AVCD repair can be performed with low mortality and low reoperation rates. Here in the graphs you can see the cumulative survival and mortality with follow-up time in this study. What are the prognosis and survival in complete AVCD and partial AVCD? Less than 2 to 3% operative mortality is seen with complete AVCD, 92% was overall survival, 85 to 90% was 20-year survival, 11% with AV reoperation in 10 years and 15 to 20% with reoperation is 20 years. In partial AVCD, less than 1% mortality is seen, near normal survival is seen, 10% have reoperations for MR at 20 years. Pulmonary hypertension is rare and atrial fibrillation risk is increased with partial AVCD. What are the factors that affect post-surgical survival? The left ventricular valve regurgitation is the primary determinant of the post-surgical survival. Post-surgical survival, the predictors of long-term survival and reoperation, moderate left atrioventricular valve regurgitation has 17% mortality, 45% progression to the severe mitral regurgitation. Age and weight at the repeat are also important for post-operative survival. Weight less than 4 kg, longer ventilation, higher inotropic requirement, longer ICU. Age less than 3 months, independent risk factor for mortality. Optimum repair should be done at 3 to 6 months with weight of more than 4 kg. Down syndrome patients have worsened prognosis. In AVCD patients, pulmonary hypertension at the repair has also worsened prognosis in these patients. Associated cardiac defect like tautology of Fallot or DORV has increased risk factor for the post-surgical survival. Left atrioventricular valve stenosis has the worst prognosis in these patients post-repair. What are the follow-up recommendation? The main thing is follow-up should be a lifelong. Annual follow-up yearly until the 10 year of age and then every 2 to 3 years of age where we perform the physical examination, the ECG and echo where we should observe for the left ventricular outflow tract obstruction. Any residual mitral regurgitation should be treated at any stage if it is necessary. Holter monitoring is advisable in selected cases with arrhythmia or the patients who have previously documented case of atrial fibrillation or flutter. Infective endocarditis prophylaxis for 6 months post-surgical and maintain good oral hygiene to prevent that. Late complication should be observed in this patient of mitral regurgitation recurrence, LVOTO and arrhythmias. Pregnancy has lower recurrence rate of 3 to 5%. Former cardiology review should be must before trying pregnancy in these patients. What is the take-home message of this study? Left AV valve quality is everything in this patient. Timing matters but weight more than age. Echo surveillance is lifelong. Left atrioventricular valve stenosis is more dangerous than regurgitation. Adult AVCD repair is unrecognized but feasible. Cleft-centered mitral regurgitation jet, early reoperation. Thank you.